Good afternoon, everyone. Thank you for joining us for an update on the Canadian Longitudinal Study on Aging. My name is Jacqueline McMillan, and I am the Calgary site principal investigator and an assistant professor in the Department of Medicine and Community Health Sciences at the University of Calgary. Thank you for joining us today. I'd like to begin today's webinar by acknowledging that as a national study, the CLSA is located on lands that are home to many diverse Indigenous nations. We respect the treaties that were made on these territories and acknowledge the harms and mistakes of the past as we dedicate ourselves to moving forward in partnership with Indigenous peoples and communities in a spirit of reconciliation and collaboration. Before we get started, I have a few housekeeping notes. Today's presentation is being recorded and live streamed on YouTube. Closed captions are turned off. To change your caption settings, select Captions at the bottom of the Zoom window. If you have questions or comments, you can type them into the Q&A box at the bottom of the Zoom window. However, please note that questions submitted in advance will be prioritized. If you have any technical issues, please use the chat box to inform our communications team. Finally, only the presenter's audio and video will be enabled through the webinar. Our agenda for today. This will include an update on the CLSA, followed by 3 presentations that highlight key CLSA findings and impacts of the study. As much as possible, our speakers have tried to incorporate the questions you submitted into their presentations. We had our work cut out for us. There were more than 250 questions submitted in advance, but we will try our best to answer as many as possible during the Q&A that will follow the formal presentations. I will now introduce our presenters. Dr. Andrew Wister is the director of the Gerontology Research Centre and a distinguished professor in the Department of Gerontology at Simon Fraser University. His research traverses several interlocking areas, addressing resilience and aging applied to multimorbidity, social isolation and pandemic adversity, baby boomer health dynamics, and environment and aging. Dr. Erin O'Day is a PhD candidate in the Department of Gerontology at Simon Fraser University. Her dissertation research focuses on the social contexts surrounding older adults who volunteer in Canada, with a particular interest in the influences of ethnocultural identity and the COVID-19 pandemic. She also works as the site supervisor for the CLSA Computer Assisted Telephone Interview Center at SFU. Dr. Ryan Falk is a postdoctoral fellow in the Department of Physical Therapy at the University of British Columbia. His research investigates how lifestyle can promote healthy cognitive aging in people at risk for cognitive decline. Major research foci include examining how physical activity, sedentary behavior, and sleep quality share an interactive relationship with cognitive health. And Dr. Tarek Amer is an assistant professor in the Department of Psychology at the University of Victoria. His research aims to understand the relationship between age-related changes in cognitive control, meaning the ability to focus on task-relevant while ignoring task-irrelevant information, and attention and memory processes. I'd like to point out the scientific leadership of the CLSA, including those folks whose pictures are presented here, including Dr. Parminder Raina, Dr. Christina Wolfson, and Dr. Susan Kirkland. We also have photos of site principal and co-principal investigators posted here and on the next slide as well. There are some faces here that you might recognize more readily because they are our site CLSA coordinators at each of the sites. I'd like to speak very briefly about the CLSA history. So as you can see, planning for the CLSA began over 20 years ago. and recruitment began in 2010. In 2021, this was marked by a 10-year data collection, and in 2015 marked 10 years since the first data release. So what is the CLSA? CLSA is both a research study and a platform. It supports population research into health and aging, leading to better health and quality of life for Canadians. CLSA is a network of collaborating institutions, and you'll see all of the many institutions that are involved across Canada here. CLSA has national scope. So as you can see here, the green dots indicate where home interviews and data collection site visits occur across Canada, all the way from Victoria to St. John's. And then the blue dots indicate where telephone interviews occur. And you can see that this is a very broad region that is covered by these interviews, home interviews, and data collection sites. The CLSA research platform enrolled 51,338 participants who were aged 45 to 85 years at recruitment. This was composed of the CLSA tracking cohort and the CLSA comprehensive cohort. Within the tracking cohort, there were over 21,000 participants enrolled, and in the comprehensive cohort, there are over 30,000 participants. Baseline occurred between the years of 2012 and 2015. Follow-up 1 occurred 3 years later between 2015 and 2018. That was followed by follow-up 2 between 2018 and 2021, and which was briefly interrupted by the COVID-19 pandemic. We are just finishing follow-up 3, which spans 2021 to 2024, and later this year we will begin follow-up 4. As you can see in this diagram, we anticipate that follow-up 6 will be the final data collection ending in 2033, and that data collection is then going to span 20 years. Participants are followed up actively every 3 years. There have been many enhancements to the CLSA platform over time. So you'll see here that in 2020, the COVID-19 questionnaire study was introduced, as was the COVID-19 antibody study. Then in 2021, the COVID-19 brain health study was introduced. In 2022, we introduced the memory study, the Healthy Brains, Healthy Aging initiative, as well as the proxy questionnaire. And here we are in 2024. Some of these initiatives are ongoing, and we are about to begin follow-up 4. Data collection through questionnaires. So as many of you have experienced, you are asked to answer a variety of questions on physical, social, and psychological health. And these questions largely remain the same over time, but new content has also been added. New in follow-up 3 was a short supplemental questionnaire. Baseline tracking data that was released in 2015 led to research about social isolation, hearing loss, risk factors for falls, retirement, and chronic health conditions. As many of you will have experienced, if you attend data collection site visits, there are a number of things that are done during these visits. Some of these things include physical assessments such as height, weight, and BMI, bone density, body composition, and aortic calcification measurement, blood pressure, ECG, carotid intima media thickness measurements, pulmonary function testing, vision and hearing, performance testing, and newly introduced activity trackers. Additionally, there are cognitive assessments looking at memory, executive function, and reaction time. And lastly, there's biospecimen collection, which includes blood and urine samples and newly added stool collection. We have newly introduced the mobility trackers, and these include tick watches as well as actigraphs, which are worn on the thigh. These track activity and community mobility, for example, driving and how broadly one's environment spans, and is eligible for all comprehensive participants. Additionally, sleep trackers have been introduced. So as you can see in this photo, this includes the Muse headband, the actigraph, which is worn on the wrist, and these track sleep quality and patterns of sleep. And eligible participants will include 2,360 comprehensive participants. Some of you may wonder about losses to follow-up in the CLSA. And what we found was that by the end of the second follow-up, 7.4% of participants had withdrawn from active data collection, though most of those, so 80%, consented to continue through data linkage. 6.9% of participants have died since their baseline assessment. We do have, however, strategies to help prevent losses, and this includes web questionnaires for participants who move outside of the area, as well as proxies who can answer questions on behalf of the participant. So follow-up 4 is a very exciting time, and I am excited for participants and for all the data that's going to be collected. Some of the new measures in follow-up 4 are eligible to all participants, so both comprehensive and tracking participants. These include additional questions on ageism experiences, as well as cannabis use. There are also some new measurements that are eligible for comprehensive participants, and this will be conducted at data collection sites. And this includes smell using sniff and sticks, as well as vision. And we are training up our staff in the DCS because, as you'll see in follow-up 4, we've added both sniff and sticks as well as stool collection, and we want to make sure that we keep everything separate so that we have no crossover on any of these measures. Okay, next slide, please. So changes at the data collection site. When you're completing your visits at the data collection sites, you might notice some changes between follow-up 3 and follow-up 4. For example, in follow-up 3, heart function was measured using an ultrasound of the neck to assess the thickness of the artery. In follow-up 4, heart function is going to be measured using cardiac ultrasound, also known as an echocardiogram, to examine the structure and the function of the heart. So how are these data that are being collected being used? The use of this data includes both projects and publications. More than 600 research teams have been approved to use CLSA data since 2014. More than a third of the approved projects are led by trainees, meaning master's students, PhD students, postdoctoral fellows, for example. Most projects are based in Canada, but many are international, for example, the United States and the UK. 350 publications have been published in scientific journals using the results and the data from the CLSA. Some of the most recent scientific publications you can see examples of here on the screen, and some of them have looked at things such as nutrition risk, social participation, successful aging, macular degeneration, physical activity and changes in cognition, and the associations between age at menopause and vascular risk and 3-year cognitive decline. So this is just a few examples of some of the most recent publications that have used data from the CLSA. There's also been some media coverage of some of the work that has been resulted from CLSA data. So there has been work that's been produced and shown in the Vancouver Sun, in US News, and in Newsweek, as a few examples. These projects and publications also have impact on policy, and you can see here that some of this impact has included agencies such as the Public Health Agency of Canada, the COVID-19 Immunity Task Force, and the World Health Organization. So there are some study enhancements also to speak about. One of those is the CLSA Weston Healthy Brains, Healthy Aging Initiative. This is a $12 million brain health initiative that was funded by the Weston Family Foundation. It involves 6,000 comprehensive participants, and it includes MRIs and stool samples for 2,630 comprehensive participants and stool samples only for 6,000 comprehensive participants. This began or launched in September of 2022. Another new initiative is the Memory Study. This was a $1 million study funded through the Public Health Agency of Canada. It investigates whether information collected through CLSA interviews can be used to correctly identify individuals who have memory problems and individuals without memory problems. 597 CLSA participants with a range of cognitive abilities completed a medical assessment and neurocognitive examination, and also identified a family member or friend for a 20-minute telephone interview. The data analysis is underway currently for the Memory Study. I would now like to transition over to Dr. Wister, who will present on the results of the COVID-19 studies.
Good afternoon, everyone. Welcome to our webinar. We wouldn't be where we are today without you, so I want to extend my sincere thank you on behalf of everyone for your participation. I'm sure you're going to hear that again. I'm going to speak about some of the work that's been done with the COVID studies. There were 3 studies, as Jacqueline alluded to, and thank you for that, Jacqueline. One was in April 2020 to December 2020, the COVID questionnaire study, which was done by telephone and by web-based approaches. It included almost 29,000 of our participants, quite remarkable. Right at the start of the pandemic. So we really got going very early on in terms of the research. And like everyone, we had to pivot and adapt and make these kinds of adjustments so that the CLSA can be useful for not only its initial purposes, but for pandemic-related research. The second study is the COVID antibody study. We had almost 20,000 participants. It was collected between October 2020 and July 2021. This entailed blood samples, and then the brain health study, as was alluded to earlier, was launched in the summer of 2021, and data collection is concluding as we speak. Next slide, please. So there's been a lot of remarkable findings, important findings that have come out of the COVID research. I'm just going to touch on a few here, and then I'm going to talk a little bit about some of my own work with a focus on social isolation and loneliness. Pandemic depression persists, especially among adults who are lonely. That came out in 2021. Female informal caregivers who provide intensive care at home experienced high levels of depression and anxiety during COVID pandemic, March 2022. Hard to change minds when it comes to vaccine willingness. That came out in April 2022. For people over 50, even mild COVID can result in mobility problems. January 2022, pandemic prompts higher intake of flu vaccines among older adults. January 2022. And 1 in 4 older adults experience changing in their alcohol intake during the pandemic. Next slide, please. So the antibody study, as I said, included quite a remarkable number of individuals providing blood samples. This was done, some of which were done at the comprehensive sites that many of you go to, but also some home-based kits as well, obviously during the pandemic, which had to be done. About 4% of participants tested positive for the SARS-CoV-2 virus, and it was higher for the 50 to 69-year-olds than the older group. Next slide. So there've been quite a large number of publications ranging from incidents of functional limitations with diabetes, increasing during the pandemic. Self-reported chronic illnesses and public health measures that were connected, the association between memory and COVID testing, the infection symptomology of COVID, impact of COVID on the mental health of sexual minority Canadians, and the effect of persistent symptoms of COVID on individuals living in the community, just to name a few. Now, you can go to the CLSA website, you can type in the search engine publications, and you'll get the full list of publications, and there's a subset for the COVID publications. Now, we do have a website coming very soon, so that might be slightly different, but I'm sure it'll be easy to navigate. Next slide, please. So here are some other major news items that reflected the remarkable work that was done using the COVID studies. CTV News, a quarter of Canadians over 45 struggled to access healthcare in 2020. The New York Times, the pandemic has made many seniors less active. The Globe and Mail, loneliness is a major factor for depression in seniors. Well, I'll be talking a little bit about that work. Older adults with cancer at higher risk for depression during COVID. And you can see a report, social isolation among older adults during the pandemic, which I'll also be alluding to. And I believe that's going to be, the link will be put into the chat. Next slide, please. And the immunity one at the bottom. So I'm going to talk a little bit about social isolation and loneliness. Next slide, please. This is drawing on some of the work that I've done with a number of different colleagues. Some of this work focuses on multimorbidity and depression, anxiety, some on multimorbidity resilience referring to the ability of individuals to bounce back from adversity. In this case, the pandemic and the effects of the pandemic on people's lives. But there's also work that was done on informal caregivers during the pandemic and the effect of that on anxiety and depression of that role, as well as both the causes of loneliness and social isolation and the effects of loneliness and social isolation in particular on depressive symptoms. Next slide, please. So we should distinguish loneliness and social isolation. Social isolation is the lack of quality and quantity in social context. So that's more of the objective connections that we have. And loneliness is the perception that we don't have those kinds of quality contacts. Next slide. Now, social isolation and loneliness are overlapping, but they also have unique attributes. I'm going to focus primarily on loneliness in most of this work, but I will allude to when I'm looking at isolation. The data that were used were from baseline 2011, 2015. That was the original over 51,000 participants in CLSA. Follow-up 1, 2015 to 2018, as you recall, over almost 45,000 people. And then the COVID studies, as I mentioned earlier. The loneliness measure was a single item. There were some others, but we looked at this one. It's a very robust measure. And we also used the CESD depression scale. That's the Center for Epidemiological Studies depression scale, which is probably the most common one used. And we used the 10+ cut point when we're identifying depression or looking at symptoms. Next slide. So let's just look at what happened during COVID with respect to this measure of loneliness. So people experiencing or self-reporting loneliness at least some of the time or all of the time, most of the time. And we see that the light, if let's look at the left-hand side of the slides, we see a light blue panel for women 65 to 74, which is the reported loneliness baseline, and then the medium blue follow-up 1, and the dark is COVID. And you can see quite clearly a big jump in the reporting of loneliness during COVID. So that's a 17% point increase, but a 67% rate increase. So that's quite remarkable. We see similar patterns across the other age and gender groups, but in particular among women. And then I think the largest increases were actually between the ages of 65 to 74 and the oldest age groups, interestingly enough. Next slide. We also examined depression, and depression did increase during the COVID. That's the dark blue bars compared to the earlier periods, baseline of follow-up. However, only for the women and men 65 to 74. And the oldest group seemed to have less depression, whether they adjusted better or not. That's something that some of our work is starting to uncover. Next slide. So what are the risk factors for social isolation based on some of the earlier work and blending that with some of the COVID work, which I'll elucidate in just a minute? We see very common kinds of factors such as advanced age, living alone, but a whole number of other ones, some of which are modifiable, some are not, low income or poverty, lack of affordable housing, a sense of community, widowhood, episodic or lifelong physical and mental health issues, challenging technology access, cost, literacy, those living in rural, remote areas. Of course, immigrant and ethnic older adults, especially visible minorities, Indigenous elders, LGBTQ, and caregivers with heavy burden, in other words, intensive caregiving responsibilities. Next slide. If we focus on the work that we were doing on loneliness during the pandemic, we find age and gender, some mixed findings, as I alluded to earlier, but higher loneliness for many of the circumstances that surrounded and were caused by the pandemic, such as experiencing personal losses and anxiety and depression. Also, lower loneliness among persons with greater resilience. Resilience being, as I said earlier, this ability to kind of bounce back from adversity and adapt better than perhaps others might do. So positive attitude and adjusting one's expectations, especially with respect to expectations around contact with others, were important. At the interpersonal level, living alone, of course, but also interpersonal social support and social networks, very important, and certainly manifested itself in terms of stronger resilience. And policy level factors, the restrictions, obviously due to the pandemic, changes the social behavior. These were associated with loneliness as well. Next slide, please. I'd like to just share with you a couple of interesting patterns related to being a caregiver. On the left side, self-rated health in the middle, and on the far right, multimorbidity. These are the associations with depression, just looking at follow-up 1 and COVID. So we see in the far left graph, the solid blue line are caregivers compared to the dotted non-caregivers. So while they both went up during the pandemic with respect to depressive symptoms, the number of symptoms, it was higher at all times for the caregiver group. The middle chart shows perceived health. So the bar at the top is fair or poor self-reported health versus good or excellent. We see both went up during COVID, steeper incline for those with fair and poor health, and again, higher rates of depressive symptoms. Similarly with multimorbidity, that's the co-occurrence of 2 or more chronic conditions. We see both went up during COVID, whether someone has multimorbidity or not, but those with multimorbidity were higher at all times. Next slide, please. This kind of research that's done by CLSA researchers often prompts additional kinds of work. In this case, I'm going to share with you very quickly some of the findings that we drew from the report that's in the chat. This is done by a colleague of mine, Laura Katawaki, for the Federal Provincial Territorial Forum of Ministers responsible for seniors back in 2021 during COVID. We looked at a number of databases, we looked at gray literature, and we did this between February and March 2021. Also Google searches. Next slide. So what we found in terms of interventions that address loneliness and social isolation is that during the pandemic, there were some quite interesting pivoting of many organizations. There were some new programs that were developed, and many of these were actually lower technology ones rather than high tech, although there were some of those as well. So we see befriending programs, volunteers that matched with socially isolated individuals who spent time with them either in person or remotely, telephone help and information lines, Telephone outreach, staff or volunteers calling vulnerable older adults for check-ins, emotional support, referral to other programs and services if needed. Senior Centers Without Walls is similarly another program that is virtual, either by telephone or web, and had an array of social and educational programs for older adults. Next slide. A few others were practical assistance. We saw a tremendous outreach of many volunteers and programs and organizations that provided meal delivery, transportation, wellness check-ins, etc. We had remote health promotion and wellness programs, many of which had to be done remotely, and technology access and training. And it was interesting that this was an opportunity to really train older adults in many ways and to use technologies that wasn't done previously. And many of those who could use technologies, those were made available through various avenues. Next slide. So I just want to finish off by thanking you and mentioning that once again, you can look at the quite remarkable spectrum of research that's been done on the CLSA website. I'd also now like to introduce Erin O'Day, who's going to be the next speaker. Erin is a PhD student at Simon Fraser University and the coordinator of the telephone lab that we have at SFU, and she's my doctoral student. So it's my great pleasure to introduce Ariane.
Thank you, Andrew, and thanks to you all for being here today. I'm really delighted to be presenting. So just to introduce myself, again, I'm a PhD candidate in gerontology at Simon Fraser University, and my PhD dissertation is focused on volunteering among older adults in Canada. And as Andrew just mentioned, I'm also the supervisor of the CLSA computer-assisted telephone interview site here at SFU, where I am right now, where I coordinate a staff of 7 telephone interviewers. So if you live in BC and Alberta and you're in the audience, I may have talked to you, or one of my interviewers may have talked to you. I also worked as an interviewer myself on and off for about 5 years while in graduate school, master's and PhD. So I have a really strong familiarity with the interviews. All right, so today I'm going to be presenting on a portion of my research that makes up my PhD dissertation. And as I mentioned, the goal of my PhD research is to really explore sociocultural and historical factors that surround older adults who volunteer in Canada. And my dissertation is comprised of 3 manuscripts, each of which represents a unique research study. But today I'm going to be presenting on study number 2, which is called Volunteering Among Older Adults and Effects of Ethnic Minority Status Before and During the COVID-19 Pandemic. So this utilizes data, as you can probably guess, from the CLSA. I use data from baseline follow-up 1 and the COVID-19 baseline questionnaire. So to those of you who are here and participated in any of those studies, just really want to thank you for helping make my dissertation possible. And I want to mention too, you can read the whole study I'm presenting on today in more detail. It's been published by the Canadian Journal on Aging. It's accessible using the CLSA website under publications. And I can also send an article to you upon request if you send me your email in the chat privately. Okay, so to begin, I do want to provide some background context about this topic area that I've chosen to focus on. So volunteering is generally a common pastime for all Canadians, with the General Social Survey on Giving, Volunteering, and Participating, which was administered most recently by Stats Canada in 2018, finding that 80% of Canadians aged 15 and over participated in some kind of formal or informal volunteer activities in the last year. Canadians volunteered for an average of 206 hours per year, and the most common places to volunteer are hospitals and religious organizations. And now moving into older adults and the aging population, as life expectancy and longevity around the world has increased, so has interest in how older adults engage with their communities and maintain good health and well-being. And volunteering as an activity has been recognized by researchers and those who participate as well as a very beneficial activity, as it can provide meaning and purpose to one's life and is very physically, mentally, and socially stimulating, providing many benefits in each of these areas. And current cohorts of older adults in Canada, so typically those 55 or 65 plus in some cases, have been identified as being top volunteers, as they tend to dedicate significantly more hours than any other age group. And their work provides immeasurable support to the Canadian society, enabling the function and successes of many community organizations. So for all these reasons, volunteering is a robust area of research in gerontology. So here's just some quick stats to back this up on older adults who volunteer in Canada. So as I mentioned, while less likely to volunteer overall, older adult volunteers in Canada do tend to contribute more hours. So those who volunteer contribute more hours than any other age group. An average of 222 hours for volunteers aged 73 to 100 in the year 2018. And so here's what we know so far with regards to the two areas of focus for my dissertation of the social context surrounding volunteering in Canada. So we know from both research and anecdotal experiences that the COVID-19 pandemic had significant impacts on volunteerism in Canada, with many organizations forced to cancel or scale down operations, as some of you may be familiar with. The research that we currently have that focuses on the impacts on older adults during this time is still somewhat limited and has delivered mixed results so far, with some describing reductions in volunteering, while others suggest stability and resiliency of older adult volunteers during this time. So lots of different experiences depending on location, health status, things like that. And we also know, in addition to this COVID context, that as the baby boomer cohort continues to age, the cultural diversity of older adults in Canada, including those who belong to ethnic and visible minority groups, is increasing significantly. And this also has an impact on volunteerism. Research in this area suggests that belonging to diverse racial, ethnic, cultural, or religious groups can have an impact on both the likelihood of volunteering and the types of volunteering activities that are chosen. But this has not yet been examined using large data sets in Canada, such as the CLSA. So there are still lots of questions, as evidence from what I just said, surrounding the sociocultural factors of volunteering among older adults when we're considering things like COVID and ethnocultural diversity. And the amazing thing about the CLSA is that it has collected data on all these areas in some way over the past 10 plus years. That is data on volunteering, data on COVID-19, and even ethnocultural diversity, although to a somewhat lesser extent, but still a little bit. And so by doing so, it allows researchers like me to explore these areas and hopefully answer questions. So using CLSA data, the purpose of this study was to compare participation in volunteer work before and during the COVID-19 pandemic, also to compare predictors of volunteering among older adults before and during the COVID-19 pandemic, and to examine the relationship between diverse cultural background and volunteering, again, among older adults before and during the COVID-19 pandemic. So for those of you who are CLSA participants, you know better than anyone that you've been participating in this study for a long time, with many interviews and maybe in-person visits as well under your belts. Because of this, we have a lot of data to work with when it comes to conducting research studies. And for my study in particular, I used data that was collected way back at CLSA baseline from 2011 through 2015, which were some of the first interviews done, as well as data from follow-up 1 interviews, which took place between 2015 and 2018, some of which I did interviews for, and COVID-19 baseline interviews, which you might recall if he participated, were conducted between April and May 2020, so the very beginning of the pandemic. So in total, I used data from about 24,000 participants aged 55 plus who participated in all three of these previously mentioned studies. And using a statistical modeling method called generalized linear mixed models, I and my research team were able to look at differences in volunteering among CLSA participants between two time points. So when participants were interviewed between 2015 and 2018, and for some data points, the baseline interviews, and then again when they participated in the COVID-19 baseline study in 2020. Okay, so in trying to understand how patterns of volunteering changed over time from follow-up 1 or baseline to the pandemic, we compared characteristics of participants that are typically associated with volunteering between these two time points to see how they might change. So some of these characteristics included income, education, self-rated health, sense of social cohesion, participation in religious activities, and variables related to ethnocultural background as well. And then a few other characteristics we looked at too were sex, marital status, household size, employment status, and living area. So I'm going to share some of our findings now. So to begin with the basic characteristics of the sample that we looked at, among the 24,000 study participants, most were female, so that is about 52%, born in Canada, identified as being Caucasian, were 55 to 64 years of age, about 41% were married or living with a common law partner. Most had received a post-secondary degree or diploma, had an income somewhere between $20,000 to $50,000 per year, lived in an urban geographical area as opposed to rural, lived and perceived their general health to be good to excellent, and participated in religious activities either at least once a day or at least once a week. So that's about 40%. So those are kind of the main characteristics of the majority of the participant sample. And when looking at participation in volunteering, we definitely saw a decrease during the early stage of the pandemic. So you can see here on the slide highlighted in yellow, we had 23 participants volunteering, engaging in volunteer or charity work during follow-up 1, compared to just 5%, just below 5% actually at COVID-19 baseline. So this represents an 18% decrease due to the pandemic. So just a little more here on key findings of this study to summarize them for you. As I mentioned, there was a pretty significant decrease in volunteering during the early stages of the pandemic, so about 18% decrease. And we found some changes in patterns of volunteering as well. So compared to pre-pandemic associations where volunteers were more likely to be female, older, 75 plus, and unemployed or retired and involved in religious activities, there was a difference in volunteers who remain volunteers during the early stages of the pandemic. So they were more likely to be young, old, so between 65 and 74, male as opposed to female, employed as opposed to retired, and not involved in religious activities. We did not find any kind of significant relationship between volunteering and ethnocultural identity for CLSA baseline or from pre to during the pandemic. So what do these findings mean? So overall, these findings provide evidence of pandemic effects on older adult volunteers in Canada. So the decrease in the number of participants who volunteered at least once a week can likely be attributed to, just the shift that we all remember really in the reality of daily life during the initial stages of the COVID-19 pandemic in Canada. During this time, again, as most of you can probably recall, older adults and everyone really were affected by public health measures, including physical and social distancing, closure of non-essential businesses, stay-at-home orders, lockdowns, mask mandates, travel restrictions, and restrictions on visitors to their homes. And as a result, the types of organizations frequented by older adult volunteers and volunteers at large, such as hospitals, religious organizations, nonprofits, were required to decrease or cease their volunteer opportunities and engagement, their typical schedules. So these changes very likely impacted both the desire and ability of older adults to engage in volunteer activities. And research, this is sort of supplemented, backed up by research that has determined when compared to younger age groups, older adults were more likely to adhere to public health safety measures during this time, which likely affected willingness to volunteer. Older adults may also have been affected by the prevailing public discourse at the time surrounding older age during COVID-19, much of which unfortunately was negative and ageist in nature. It typically oftentimes framed older adults as sort of victims and vulnerable, and such discourse may have affected older adults' willingness and confidence to volunteer during this period. And so, as I mentioned when discussing the findings, associations between volunteering and age, gender, and employment status were found to have changed when comparing pre-pandemic volunteering to volunteering during the pandemic. So while volunteering, again, was before the pandemic, was more likely among older adults who were older, that is 75 plus, female and unemployed, the opposite was observed at the COVID-19 baseline, where it was found that being younger, 55 to 64, male and employed, was associated with greater likelihood of volunteering. And while our data, was not able to provide information on the exact reasons for these observed changes, we do know that COVID-19 pandemic challenged all aspects of daily life. And so it's possible that younger older adults during this time, 55 to 64 in our definition, may have felt less vulnerable during this time period than older adults, age 75 plus, which could have impacted their desire to volunteer. Older women may have been more likely during this time to be called upon by their families to engage in spousal and family caregiving and grandparenting during this time, making volunteering outside the home less likely. And employed older adults may have found more time to dedicate to volunteer activities with changes in work from home and work flexibility during this time as well. So to wrap things up, findings from this study revealed the significant impact that the COVID-19 pandemic had on older adults' volunteering activities, while also revealing new associations between human, social, and cultural capital and volunteering. Disruptions to older adults' volunteer trajectories could have lasting effects and will likely impact older adults' decisions related to volunteering in the future. And this is something I'm, very interested in looking into with my future research. And these findings should be considered by those attempting to establish, maintain, or reignite volunteering opportunities for older adults, including policymakers, leaders of community organizations that rely on older adults volunteers, and coordinators of volunteer programs, because across Canada, we are still seeing the pandemic effects in terms of decreased volunteer engagement, concerns about safety, et cetera. It's very important that volunteer organizations learn from the COVID-19 experience and attempt to create a safe space for older adults who wish to engage in volunteering, even amidst future potential health crises. And, when conducting research studies, we always think about the potential shortcomings of our own studies so we can expand and continue research in the future, which I hope to do in this area. So definitely by utilizing a national representative sample of older adults, thanks to the CLSA, this study has great advantages in terms of statistical power, just having this large sample to draw from. But this data is quantitative in nature, so we have a limitation in terms of underrepresentation of specific ethnic groups in the CLSA, which was another aspect I was interested in. Meaning we don't know the full extent quite yet of older adults' volunteer experiences or the reasons for continuing or discontinuing volunteering during the pandemic. So that's a really interesting area for future exploration. And while I feel this study helps to confirm what occurred with respect to patterns of volunteering among older adults in Canada during the outset of the pandemic, future qualitative research, so where we actually go out into the community and people's homes and talk to them about their experiences, could help explain why these challenges occurred. And this could be achieved by asking older adults more in-depth questions related to their access to volunteer opportunities during the early stages of the pandemic to understand why some were able to continue volunteering and some were not. And future waves of the CLSA data, as they become available to researchers, like follow-up 2, follow-up 3, should be utilized as well as they become available. All right, this concludes my presentation. Thank you very much for listening. And I hope you enjoy the rest of our panelists and presentations today. Thank you.
Hi, everyone. Uh, okay, great. I'm unmuted now. Sorry about that. As I was saying just a moment ago on mute, my name is Dr. Ryan Falk. I'm a postdoctoral fellow at the University of British Columbia here in Vancouver. And first, before I say anything else, I'd just like to thank all of you for your time and participation in the Canadian Longitudinal Study on Aging. Really, would not be possible without all the energy and time that you've already invested in this. And so I am really grateful, as the Canadian Longitudinal Study of Aging has been something that I've been working with now for somewhere in the neighborhood of about like 4 or 5 years. And so it's been pretty heavily involved in my research career. In addition, I'd just like to acknowledge that the work that I'll be sharing with you today was conducted in terms of the analyses and the write-up on the traditional homelands of the Musqueam, the Squamish, and the Tsleil-Waututh nations. And I'm very grateful to be living and working on those lands. Okay, so in terms of what I'm going to be sharing with you today, what I'd like to talk with you a little bit about is something called the 24-hour activity cycle and its impact on brain health. So first, we'll talk about what that actually entails, and then we'll talk a little bit more about how this 24-hour activity cycle can impact our brain health, particularly as it pertains to findings from the Canadian Longitudinal Study on Aging. And then finally, I'd like to share with you some next steps that we're planning using data from the CLSA. Okay, so first, what is this 24-hour activity cycle? Well, first, let's just talk a little bit about how our cognitive health changes as we age. So I think most of us are aware that as we age, there is a normal process of changing in terms of our cognitive abilities. And while this is a natural part of the aging process, some individuals are going to experience greater cognitive decline than expected for their age and education level. Now, what I'm really interested in terms of my research is I'm interested in trying to understand what the differences are in these cognitive trajectories and what are the underlying reasons for why one individual may experience a greater cognitive decline than another. And one thing in particular that I'm interested in exploring is how things like lifestyle factors can help to prevent further cognitive decline and may be able to help to reshape our cognitive trajectory as we age. Now, one thing that can have substantial impact on our cognitive health is the 24-hour activity cycle, which consists of 3 behaviors: physical activity, sedentary behavior, and sleep. Now, each of these behaviors makes up most of the 24-hour day. So they make up, if we were to add up all the time you spend in sedentary behavior, physical activity, and sleep, that would encompass most of the 24-hour day. And thus we refer to it as a 24-hour activity cycle. So as I just mentioned, this 24-hour activity cycle consists of physical activity, sedentary behavior, and sleep. And each of these behaviors are at least independent of one another, meaning that you can't engage in one while also engaging in one of the other 2. But it is important to note that they are interdependent with one another, and they're also pretty heavily related to one another through something called the circadian cycle, which is roughly the 24-hour biological clock, which helps to regulate our sleep-wake cycle with the solar light-dark cycle. It's important to also note that these behaviors are energy independent, meaning that they have different energy expenditures, and we can also classify them as either wake-based behavior or as sleep-based behavior, meaning that they occur while we're either awake or whether we're sleeping. Okay, so just very briefly, physical activity is one of these 3 behaviors, and it is broadly classified as any bodily movement that helps to increase energy expenditure above resting or basal levels. Now, this can include things like household activities such as sweeping, washing, vacuuming, doing laundry, dishes, anything of that sort. And then it can also be things like occupational activity. So like something that you might do for work. So for instance, if you work in construction, then that would be a physical activity that would, or an occupational activity that would have a high amount of physical activity. It can also be transportational activity. So using public transportation, going to the bus stop and then getting on a bus and then leaving that bus. That's a form of transportational physical activity or active transport. And then finally, it can include something like exercise, which is broadly leisure time physical activity for the purposes of trying to increase or maintain physical fitness. Now, it's important to note that somebody can be pretty physically active without necessarily ever engaging in any exercise. So this is always something that I like to bring up with people is that, yes, exercise is great. I think that it's something that everybody should engage in if they can, but it's important to know that you can still be very physically active even if you're not exercising, several times a week. Now, sedentary behavior is a newer concept in the literature, and it's something that refers to any low energy behavior which is done from the seated or lying position. Now, this includes things that we're probably pretty familiar with, such as screen time or television time, watching a computer or doing what I'm doing right now, talking on my computer while sitting. It can also be transportational in nature. So for instance, if I'm driving my car somewhere, that would be a transportational sedentary behavior. Reading can be a sedentary activity as well. Socializing is often done while we're sitting, whether it be at a pub or just in our home. And then also for younger people, at least schoolwork is oftentimes done while sedentary as well. Now, sleep is a little bit more difficult to define, but the most common definition for sleep is it's a rapidly transitionable neurobiobehavioral state that is typically characterized by postural quiescence and then also recumbence and closed eyes. Now, in terms of what we look at when we're trying to classify what sleep is, we're typically talking about a number of different things in terms of our sleep quality or our sleep health. But the most important aspects of our sleep are going to be its duration, so how long you sleep each night, and then also the efficiency of our sleep each night as well. So efficiency would be the amount of time that we spend in bed actually sleeping versus the amount of time that we spend in bed trying to sleep. Also, I'd like to just mention that there are now available guidelines on the 24-hour day and what we should be doing that are available across Canada. And broadly, these guidelines suggest that people should be getting about, or older adults should be getting about 7 to 8 hours of sleep. Adults 18 to 64 should be getting 7 to 9 hours of sleep. And then that for older adults, at least, in addition to getting 150 minutes per week of moderate to vigorous physical activity, which is something that's recommended for all adults as well, that older adults should be trying to engage in challenging balance activities as well to try and maintain our balance as we get older, and that we should all be trying to limit our sedentary time to less than 8 hours per day and no more than 3 hours of recreational screen time. Lastly, I'd just like to share with you that in terms of this 24-hour activity cycle that I'll be talking a little bit more here about in a minute in terms of the research, it's also important to note that it's not just about these three behaviors and their impact on cognitive health, but it's important that we recognize that there is an interdependence in terms of all these other social determinants of health that can impact this 24-hour activity cycle and impact our cognitive health. And this can include things like socioeconomic status, our place of residence, our race and ethnicity, education, and all these things can really interplay and impact both the cycle and also how it impacts our cognitive health. Okay, so what have we learned specifically from the data using the CLSA? So the first study I'd like to just briefly share with you is something that looks at whether there are age and sex differences in the associations of physical activity and sleep with cognitive function. And so for this study, we used baseline data from the comprehensive cohort. And for this, we then looked at a three-factor measure of cognitive function using the full neuropsychological battery that's available from the comprehensive cohort. And we looked at three major domains of cognition, specifically memory, executive function, which is broadly a higher level thinking or planning behavior that is something that is important in order to help to allow us to do more complex cognitive tasks. and then also verbal fluency, which is our ability to use and recall words in a very large, broad semantic categories. Next, we also looked at physical activity using the physical activity scale for the elderly, which is a questionnaire completed by all participants in the CLSA. And then we also looked at self-reported sleep duration, which is something that was provided by individuals in the comprehensive cohort. So first, what I'd like to share with you is that there are differences in terms of our cognitive performance as we age. And so in here in green, you can see females, and then in males, we can see those individuals are in purple. And what we can see is that there is a significant difference in terms of males and females in terms of their cognitive performance, with females performing better on all cognitive domains from middle adulthood and into older adulthood. And this is something that's pretty consistent with the literature to date. In addition, we also see that males are more physically active than their female counterparts in middle adulthood, but that there's that difference in terms of physical activity level, it starts to attenuate as males and females age. We also see that in terms of sleep duration, that you can see on the right-hand side, that sleep duration doesn't really seem to differ that much between males and females in terms of how much sleep we report. So most males and females report about 6.5 to 7 hours of sleep each night from middle adulthood onward. Now, there are some interesting effects that we did find in terms of the relationships of physical activity and cognition based on age and biological sex that I'd like to share with you. And so for right now, I'm just going to focus on one cognitive domain, being executive function. But these findings that I'll share with you right now were pretty consistent across the other domains as well. On the left-hand side, you can see the relationship of physical activity with cognitive function based on age and biological sex. And what we found is that irrespective of whether someone was male or female or what someone's age was, that individuals who were more physically active had better cognitive performance. So this suggests that physical activity is beneficial for cognitive function, irrespective of someone's age or biological sex. However, we found a much more complicated relationship between age, sex, and sleep duration in particular. So on the right-hand side, you can see that for females, females who slept shorter periods of time as they aged, that difference was actually associated with better cognitive performance in comparison to females who slept longer durations. By comparison, for males who slept shorter durations in middle adulthood had better cognitive performance than their peers who slept longer durations. But that difference between those two groups, those who slept longer and shorter, actually attenuated as they aged. So we see that there's this complex relationship that seems to exist between sleep duration and cognitive function between males and females. So next, what I'd like to share with you is some data that we just recently published as well, looking at whether socioeconomic status moderates the relationship between physical activity and cognition. And so these data were collected from baseline and follow-up 1 using both the comprehensive and the tracking cohorts. And specifically, we used a 2-factor model of cognitive function, specifically looking at memory and executive function. And the reason that we did this is because for the tracking cohort, there's not as many cognitive tests that are performed. So we had a more limited number of cognitive measures that we could include in our model. And thus, we only looked at 2 specific domains of cognitive function that were available in both the comprehensive and the tracking cohorts. We then looked at physical activity, again, using that physical activity scale for the elderly, the self-reported questionnaire on physical activity. And we also looked at socioeconomic status using the material and social deprivation index from CANU. What this is a measure of, it's a measure of both material and social deprivation of an area that's given based off of residential factors. And we can see from material deprivation, that would be consistent in terms of the material resources that are available in an area, with higher material deprivation scores being indicative of greater material deprivation. And then for social deprivation, that's a sort of a measure of how socially isolated individuals might be in that area or what sort of social resources are available. And again, with higher scores on that being indicative of somebody that is living in a more socially deprived area. So in terms of the effects, we actually found some interesting things when we stratified individuals by their age group. So we stratified individuals into groups of 45 to 64 years of age and then 65 plus. And what we found is that there was a significant relationship between physical activity and cognition, irrespective of the material or social deprivation of an area for individuals over 65 years of age, suggesting that physical activity was important for cognitive function, irrespective of how materially or socially deprived an area was. By comparison, we found some very interesting moderating effects for individuals between 45 and 64 years of age. In panel A, what we found is that as social deprivation scores increased, that showed that there was a stronger relationship between physical activity and changes in cognitive performance from baseline to follow-up 1, suggesting that physical activity had a greater effect on helping someone maintain their cognitive function, specifically their executive function, in more socially deprived areas. We found, in addition, similar results when looking at changes in memory, specifically for material deprivation, wherein for individuals who were living in more materially deprived areas, that there was a stronger relationship between physical activity and changes in memory performance, where again, greater amounts of physical activity were associated with greater maintenance of memory from baseline to follow-up 1. What this suggests is that physical activity is important for cognitive function, irrespective of whether someone is 45 to 64 or over 65 years of age. And more importantly, there may be some important relationship between social and material deprivation and their relationship with physical activity and cognition, where physical activity may be especially beneficial on people that are living in more deprived neighborhoods. Okay. In these last 1 or 2 minutes, I'd like to just share with you some next steps that we have. So today I've just really focused on looking at socioeconomic status and its impact on the 24 activity cycle and cognition. But there's also all these other factors that we haven't really explored yet. And it's important to note that each of these factors are related. So they don't just happen in isolation. It's not just like socioeconomic status doesn't really also depend on where you live, race or ethnicity or anything like that. So it's important that we remember that these are all interrelated and we need to explore these a little bit more. In addition, one thing that we would like to look at a little bit more, and we're currently in the process of submitting for publication, is looking at how the pandemic may have affected the 24 activity cycle and cognition. So we know that the COVID-19 pandemic has had negative consequences on brain health, but we also know that the COVID-19 pandemic had some pretty substantial impacts on people in terms of the 24 activity cycle, with decreases in physical activity, increases in sedentary behavior, and probably some changes in sleep as well. And so thus, it's possible that these changes in the 24 activity cycle may also have impacted our brain health. And so that's something that we're hoping that we'll be able to explore more in the coming years, especially with this new data that's coming from the Western Brain Institute funding and project. And so with that, I'd just like to say thank you to all the great people that I have the opportunity to work with here at UBC, including my supervisors, Dr. Teresa Lou Ambrose, and then also Dr. Roger Tam. And thank you for your time, and I'll hand it back over to Jacqueline.
Awesome. Thank you, Dr. Falk. That concludes our formal presentations, but I would now like to open it up to questions. I will start with questions that were submitted in advance. And just a reminder, muting will remain on, but you can enter your questions into the Q&A box in the bottom of the Zoom window. So the first question, this was submitted in advance. What are the most important proactive actions identified by the CLSA that have positive impacts on healthy aging? I'll open it up to the panel. I don't know if there's anyone in particular who would like to answer this question.
I'm happy to jump in. I'm sure there'll be others. I hope you've got about 2 hours for this answer. But no, there's been considerable work on so many different areas. But I'll talk about healthy lifestyles, and this is an area that you can see even from the talk today. There's been some emphasis. So typically we think about just the typical kinds of lifestyle factors that are important: physical activity, nutrition, not smoking, not drinking too much. And there's been additional work in a number of areas that's really important and cutting edge. So the area of sleep, for example, has been found to be extraordinarily important. We look at other aspects of lifestyle, such as the reduction of stress. Um, there's a whole range of other factors, but I think what's important in healthy aging is not doing well on one or two, but doing well sort of on a number of these, because there's these kind of complex interactions among them. Take for example some research on Alzheimer's disease that shows that whilst people can be predisposed through a particular genetic marker, that switch may not be turned on if they have healthy lifestyles with respect to omega acids and physical activity and so forth. Brain health, we know that a lot of these factors are extraordinarily important. So it cuts across a lot of things. And I'll say this, that it's very important to develop these lifestyle behaviors, which are routinized forms of behaviors in your life as early as possible. But it's also never too late to re-engage them, to foster them, and to engage in these lifestyles to the best of your ability. Now, of course, there's resources and other barriers and motivation and health factors that constrain us. If one has a very sore knee due to arthritis, it's difficult to jog and maintain your physical activity. But you can find ways to overcome these challenges, and I would just encourage people to do so, because I think that's an enormous set of factors in how we age. Thank you.
That's great. Thank you. Thank you, Dr. Wister. Another question that was submitted beforehand. As we age, are there cognitive tests, exercises, or activities that are recommended? And I'll open that up to the panel again. Dr. Falk.
Yeah, so I think that's a really good question. So broadly, when we talk about activities that somebody should be doing, I would say that the general evidence is that doing as many different activities as possible is going to be the most cognitively stimulating and going to be the best in terms of helping to maintain brain health as we age. So that can include things like just traveling. It can include things just like walking outside, for instance, going for daily walks. It can also be doing things like crossword puzzles or Lumosity or whatever it may be. I think one thing that we seem to see is pretty important is doing as many activities as possible and trying to have, a wealth of activities. Socializing, all these things are going to have the most net benefit. In terms of specific exercises, like in terms of like an exercise program or something like that, there's not really any clear evidence about whether there's one particular type of exercise that somebody should be doing. What seems to be the most beneficial thing is doing whatever exercise you find to be the most enjoyable for you and something that you feel like you can continue to do, for a long period of time. Not meaning like in 1 hour or 2 hours, but over the span of months, weeks, months, days, and years. And I think those are going to be the things that are going to be really important. So if that's walking, that's totally fine. If that's, doing cycling or weightlifting or something like that, then, that's great too. And if you can do both of them as well, even better. But it's really comes down to what you feel is something that's going to be maintainable over, the stretch of your lifetime.
That's awesome. That's great. Thank you. Has research been done on the health effects on elderly women or men functioning as full-time caregivers to their elderly partners?
I'm
Go for
sorry,
it.
and I don't want to hog. Andrew, do you want to go first?
No, you go, Ryan.
Yeah,
Jump
just
in.
really quickly. That's a great question. In terms of Alzheimer's disease and dementia, there is a large amount of evidence that shows that women are more predisposed towards Alzheimer's disease and dementia in general, and that may have something to do with biological aspects and hormones, but there's also a large degree of caretaking that goes into it as well. So women are more likely to be caretakers, and that there's a lot of stress that's imposed on caretaking that can also have negative consequences on health as well. So yes, unfortunately, I can't really say specifically to taking women who take care of their elderly spouses, whether they're men or women. But overall, caretaking does seem to have some potentially negative consequences on health as well.
Yes, and I'll just chime in. There is a paper that was involved in where we looked at the healthy caregiver effect. And so there is a selection factor with caregivers, so you have to be careful how you look at this. So what Ryan said is absolutely true, but again, you can run into these statistical artifacts whereby it seems like that you're not finding that kind of expected association that was alluded to. So indeed, because of the selection effect, more healthy people are caregivers. If you compare them to non-caregivers, you won't see the kinds of things that Ryan's alluded to. But when you drill down into that association in a number of ways, you do find it. So it's interesting, and it shows you how important it is to have the kind of data that we have in the CLSA and the quality of researchers to really to think deeply about these issues so that we come up with the answers that are going to help to direct better living policies and practice. Thank you.
That's great. One question that was submitted ahead of time was, how do you assure consistencies in practice over decades and with so many tests involved? And do you ever carry out audits?
Maybe I'll jump in here from a site perspective. There's a lot of quality control in this study. At the site level, certainly staff training is a key component. When new staff come on board, looking at the SOPs. So a lot of this is standard operating procedures, making sure that staff are following that, doing regular checks at the site level to make sure that staff are not deviating, especially if they've been with the site for a long time. We're also extremely lucky in this study, I think, in that we have McMaster folks at the National Coordinating Center doing regular checks for us as well. So if we're not doing it at the site level, or not doing it as regularly at the site level, we get regular feedback on how well we're doing, which is a big effort, I think. I say on the National Coordinating level, but I think it's actually at the Data Analysis Center, which operates out of McGill. There's a lot of folks making sure that the quality of data is there on a day-to-day basis, on a I'm going to say on a quarterly basis, but sometimes it's more frequently than that, and on a yearly basis. And then as the phases finish off, as each phase finishes, there's a quality check of what's coming out. So when we're looking at what does the quality of the data look like for baseline, we can be sure that it's there. We can look at it for follow-up 1. We can look at the quality of the data for baseline and follow-up 1, et cetera, and as we move along. So very, very important to make sure that we're getting good quality data along the way, but also making sure that as we go from one phase to another, that it's there, making sure that as sites change, the staffing within sites change, that the quality is maintained. Thanks.
Thank you so much for that, Joanne. I'll open this one up to the panel too. Why are we not given the results of the various tests? For example, cognitive test, lung capacity, ECG, etc.
I can just briefly answer about the cognitive tests. For the cognitive tests themselves, uh, they're not for diagnostic purposes more often than not. We're actually typically just looking at how somebody thinks, and it's more of just a measure of some cognitive abilities in some specific areas. They're not something that can be used for any sort of diagnostic purposes. So they can't be used by a physician or anything to be able to diagnose, or be able to identify someone's risk for Alzheimer's disease or dementia.
For a number of the tests, if there are anomalies, then we have a protocol to deal with those anomalies. I think that was answered in one of the Q&As earlier as well. But otherwise, yes, we don't share all of the different tests, and there's a number of reasons for those, I think, that were alluded to. Thank you.
And I guess sort of in follow-up, how much information is sent to my GP? Are they informed of any significant changes in any of the tests done?
The GPs are not informed, and I think we've explained that.
Okay. Let's see here. I think we might have only.
This is Parminder, I can address the question of GPs. When we first started this study, one of the things we considered, because of the privacy and confidentiality and the ethics, that we needed to have individuals consent to send their information to their family doctor. And after a lot of consultation and discussion, many people didn't want us to send their health information to their family doctors. So we decided we won't do that for this study. But if a participant came to us and said, I want this information to be sent to my doctor, with their permission, we can find that piece of information through them, send it to their physician. So it's not a straightforward issue of sending information to the physician. Secondly, as Ryan had mentioned in his response, that much of the data we collect is under the research setting. So in order to make a clinical decision, you need the clinical context. And if we started sending all this information to your physicians, they will get overwhelmed by this information and not know what to do with it. So it's a bit more tailored. If there's an issue we see in your data we think might require clinical attention, then we contact you with your permission through our site physician. We contact your doctor to see if you can get back into the health system to follow up what's going on with you. So those are some of the reasons that we don't generally send all this information to physicians, because it's hard to interpret this information out of context.
Yeah, that's so key, Dr. Reina. I think as a clinician, I think that certainly is an important thing to consider, that there's a lot more context than just numbers. So we treat patients and not numbers. So a number might not fall within a normal range, but we need to consider the patient context and what may have led to that. And that often takes a lot more time. And that's why the family physician is the best place for that to be addressed. Okay, I think we could go on and on with questions here. We're just getting rolling, but I want to be mindful of everyone's time. And so this will conclude our Q&A session. I will now pass it over to Dr. Ammer, who will provide closing remarks.
Okay, well, thank you everyone, and thanks to everyone who stayed till the very end. Just here to wrap it up, and a few things of note. So first thing, if anything changes on your end, like there's a change in contact information or you want to update anything, there are multiple ways you can get in touch. First, you can call or you can email at info@clsa-elcv.ca, or you can also use the website. A lot of the questions we get also have to do with findings from the different studies that we're running at CLSA. So if you're interested in that, feel free to visit the website. There's going to be a new updated one. More on that in a couple of slides. And also I'd like to note, if you are able to complete the feedback survey, that would really be super helpful, because we'd like to do more of those webinars, and your feedback is really valuable to help us improve those. Next slide. Yeah, so we've had a couple of those webinars in the past, including one that was last year around this time, and another one that was also had an in-person component at the University of Victoria. So as I mentioned, we're hoping to do more of those, so your feedback is really important. So here's the website that I was mentioning. There's a new one. It is improved. It increases accessibility. It's easier to navigate. And it also has a database of all the different projects, their descriptions, as well as the findings if you're interested in that. And also if you're trying to access it through your mobile device, it is optimized for that as well. And finally, I would just like to thank all of the funding agencies, particularly the Canadian Institutes of Health Research, or CIHR, and other provincial governments and universities as well. And of course, I would like to thank you for your time. Of course, the CLSA is nothing without its participants. So again, thank you so much for all the time and the effort that you put into this, and also for attending this webinar.